Hi, welcome everybody. My name is Sarah Clute-Bain. I am the Boone County Hospital Foundation Director, and I'm so pleased today to share yet another Educating and Empowering You program with you, our community, and of course, as always, this is recorded so we can send this out and share this information far and wide. I want to first start off by saying that we are going to be transitioning out of recording. Well, we're going to continue to record and do a WebEx, but we're also going to start meeting back in person, hopefully next month, April of 2024. So if you are watching this, please take note of that, and we will get those details out in our usual formats via the newspapers, social media, all our normal outlets. So really excited about that. We had some people request that, so we're looking forward to having people back in person here at the hospital. Today, I'm really pleased to introduce Mikel Brandhorst. He is a pharmacist here at Boone County Hospital, and I am always appreciative of having our very own experts here from Boone County Hospital to share with you all, our community, the wealth of knowledge and experience that they have. And this in particular, I find to be very fascinating. Today, Mikel is going to talk to us about responsible antibiotic use and how the overuse and misuse of antibiotics can lead to resistance of infections, so making infections more and more difficult to treat. So I am going to turn it over to Mikel and let him share a little bit more about himself, his background, and dive into this fascinating topic. So turn it over to you, Mikel.
All right, thank you, Sarah. Appreciate that. It's my pleasure to be with you guys today to talk about the responsible use of antibiotics. And I got the title on here, antibiotic stewardship, which just really means taking care of. Stewardship just really means taking care of something. It could be stewardship of your finances, of your health in general. In this case, we're going to be talking about how are we taking care of or being responsible with using antibiotics. And we'll talk a lot about that today, but just a little bit about myself. Sarah already introduced me, but I live in Madrid and with my wife, Ann, and 4 kids down there, and they go to the Madrid School District. I've been a pharmacist since 2006. It kind of had a little bit of a winding road with that because I took about 5 years to teach in high school science between about 2018 and 2022, and then I've come back. So we did move away from Boone County for a little bit. I was previously pharmacist here at the hospital for 10 years, and then we moved away when I started teaching, and then we moved back because we loved it here, and we love Boone County, and we missed our church and those types of things. And then I was fortunate enough to be able to come back to Boone County Hospital in the position that I had before. So I just put a little plug in for Boone County Hospital before we get started. It's a place that's very special to me, not just as an employee. It's always been a great place to work, but also as a community member. And I've had 3 of my children here. We've had a lot of our health care done here at Boone County Hospital, and it's a great place, and just really will always be a special place for me. And so I'm happy to be here today to talk about this antibiotic stuff with you. So let's go ahead and get started. I've got a presentation. Let's see if I can make it work here. There we go. All right, so this is a presentation that I've used for a group of high school students. I went out and did this at Madrid a couple months ago, and just talking about antibiotic stewardship. So I thought I'd use the same one. It seemed appropriate. So there might be a few things that are a little more interactive, but and with the webinar here, it's a little bit different. But we'll do our best here. So the question I would pose is, what would you do in this situation? So this would be a common situation. I'm not going to give you a lot here. Just going to give you kind of a real bare bones situation. I've got a patient that came in to the ER and they had a urine culture done. And you can see the little graphic here. There's a red bacteria, all right, and then there's this blue bacteria. So there's two bacteria that were grown out on this culture. And in a real sense, there'd be a lot more than this, but just for the graphic, we'll just say that there's that many. So what would you do? Would you give A, cefepime, B, penicillin, or C, no antibiotics? And you can see we've got a little key down here about what does what. So just pause for a second here. And if you are coming in here and just watching this on your own at another time, you can pause the video and just think about this for a minute. Right, so hopefully you've had some time to think about this. Coming back, you've paused. And so this is actually just given only this information is probably not enough information to make a decision actually. So it's kind of a trick question. You really need more information. Back probably 10 to 20 years ago, maybe this is all the information that would have been needed for a doctor at this point. We probably would have said, okay, we see these two bacteria here, the red one and the blue one, and that means that cefepime here, that's the only one that kills both of those. Now, penicillin, that's a nice drug, but it doesn't kill this blue one. So let's give this patient cefepime, give them a 10 to 14 day course of some sort, or maybe less, and we're going to kill that bacteria and we're good to go. So that's kind of the way it would have been before. But the new answer is we don't really know yet. We need more information. We need to investigate this situation a little bit more. So we're going to do that here. I'm going to give you a little bit more information about this patient. This is a 65-year-old female who came to the ER with a concussion and confusion. A urinalysis, which is just pee in a cup. They're gonna perform this analysis of your urine. Is going to show bacteria in the urine. Okay, it showed bacteria in the urine. So as a result, they did a urine culture. And another piece of information is that the patient has no symptoms of a urinary tract infection. So now what do you think? Just pause the video here and think to yourself, does that change my answer up here? And so now coming back to this, I'll kind of give you my input, is that we would give no antibiotics in this situation. Even though we see bacteria here that are growing, you might be tempted to think, well, those shouldn't be there. We need to get this taken care of. But actually, what we look at is this idea here that the patient has no symptoms of a urinary tract infection. And so what we would say is that, yeah, there are some bacteria there, but the patient does not need to be treated at this time because it's not causing a illness. The patient's not ill from it. In fact, you may be sitting there right now with no symptoms. You may not have painful urination or frequency or hard time urinating, and you might have some bacteria in your urine, but you wouldn't go to the ER right now because you don't have any symptoms. And so what we're finding is that these can many times resolve themselves. The patient can take care of their body's immune system, can take care of those bacteria on their own and don't need any assistance from antibiotics. So that's kind of just a little bit of a nutshell what we do every day. There's a lot more to it, and I could talk for a long time about it, but I'm not going to. I'm going to give you kind of the bare bones of it and the interesting portions here. So just kind of moving on here, what I want to do is just take a step backwards and think about the history of antibiotic use and how that ties in. I kind of like history, so I have a hard time not bringing history into things. So a couple questions here that we want to just think about to begin with. How are bacterial cells different from human cells? And the importance of that question is how antibiotics do their job. So what is an antibiotic? What it does is it exploits the differences. Okay, so bacterial cells have different structures than human cells. Human cells have a nucleus that's bound by a membrane, but bacterial cells do not. Bacterial cells have a substance called peptidoglycan, whereas human cells do not. There's many other subtle differences. And what we can do with an antibiotic is say, okay, since that bacteria has this peptidoglycan, what can we prevent that peptidoglycan from developing? We don't need to worry about it in the human cell because we're not going to disrupt the human cell's growth because it doesn't have that structure. So that's what an antibiotic does. The analogy would be kind of like cancer. Okay, only difference in cancer is now we're talking about both are human cells. There's human cells that are cancerous, that are uncontrollably replicating and are mutated in some way, and the normal human cells that we want to keep. So that's a little bit more difficult because they're a lot more similar than bacteria in human cells. But that's a whole nother branch of medicine, but we're doing a better job at figuring out ways to exploit the differences between the cancer cell and the human cell so that we can kill the cancer cell while keeping the healthy human cell. So antibiotics are targeting these bacterial cells different from human cells. All right. So this is a graph that I just plopped in here. It doesn't really have anything to do with antibiotics other than it does a little bit. And I want to show this to you because I find it very interesting. So this is the estimated global population on Earth. So this is a bit arbitrary. Thousands of years ago, humans started inhabiting the Earth. It's debated about like what was the actual beginning there. But let's just say for our case that it's 10,000 years BCE here. And you can see that for the most part of human history has been slight growth, right? Slight, slow growth of human population throughout, even though we're out here to the 1200, 1400 AD. And then something happens. Something happens here in the 1800s, early 1900s, and then this population just skyrockets. It's almost like we broke through constraints that had held us down before, like disease and illness and war and famine and these things. And all of a sudden, the human population has been able to sort of break through and overcome all that. And what I want to mention is that right around in this time period, amongst many other things, by the way, farming and fertilizer allowed us to grow a lot more food more cheaply, allowed people to survive, or families to be able to get food that maybe couldn't before. And so that happened. But along with that, and other technological advances, we had the invention, or the discovery, I should say, of antibiotics. And that revolutionized healthcare at that point in time, to the point where, these are miracle drugs at this time. And we don't think of them as miracles anymore, although we should, but because we've always had them. But at that time, you would have maybe gotten an illness that we can now treat, and you might have died from it at a young age. Now we can treat those relatively easily. And for instance, the plague that plagued Europe at the time, back in I can't remember the time frame, it was in the medieval ages, somewhere. I'm going to butcher that because I'm not a historian, but it would be treatable today. We have antibiotics that can treat that sort of thing. So it's interesting to see that and put that in perspective. And we're only talking less than 100 years ago, a lifetime ago, that we've had these agents to be able to use to our advantage. Another little piece of this history. So another way to look at this. So thousands of years ago, human history begins, and there's this ... that whole period of time, all the way up to 1850 seems like a long time ago, but in the whole of human history, it's not that long ago. This germ theory was proposed. We didn't even know that things were considered germs, that these invisible things we now know are bacteria. We can see them in a microscope. But then they didn't even know what was causing, maybe you got a cut and then you got an infection. They didn't even know what was causing that. And then from there, we discovered penicillin. In fact, we didn't, but Alexander Fleming did. Kind of a neat little side story. Alexander Fleming was a scientist who was studying or growing bacteria on these agar plates, the Staphylococcus, and he left for the holiday weekend. So it was a nice long weekend. He came back and discovered that there was mold on it, just like a loaf of bread, an organic loaf of bread. If you've ever left that for a couple of days, it's now got mold on it. And so he discovered these mold spots on there. And even something more astonishing, instead of just throwing it in the garbage, he noticed that there was a ring around that mold where the staphylococcus was not growing. It kind of approached it, but it wouldn't get close to it. And that was his first, he discovered penicillin there. He didn't know it was penicillin at the time, but he discovered that there's something about that mold that's preventing that bacteria from replicating or from getting there. So that was the beginning of that. And a huge effort was placed to put a lot of money and research into developing this and potentially using it in humans. And in 1941, penicillin was first used on a human being. And it took a lot of manufacturing process to do it. And it wasn't available large scale till 1945. You might know, or a little bit about around this time was when we had World War II. And so we were able now, kind of toward the end of the war, to treat soldiers who were on the battlefield and had a laceration or a limb cut off or something. They were able to get this antibiotic, this life-saving antibiotic, instead of dying from that. So 1945 is when the normal public would be able to get a prescription for this first antibiotic. And so that, I think that's a little bit interesting, because you notice that this is not that long ago, right? 1945, we're talking 79 years ago. It's not that long ago. So let's just talk a little bit about what antibiotics do, just in general terms. All right, so this is kind of a graphic to show this. You get exposure to a bacteria. Maybe you get a cut, somehow it gets past your skin, maybe gets in your lungs, a bacteria that shouldn't be there, right? And so this bacteria does a really good job of multiplying. And I'm just showing a few here, but these things multiply by the thousands and millions, right? So starts multiplying and replicating and replicating. If it replicates enough to the point where our body can't overcome it, well, now we have an infection. Sometimes our body does overcome. Our immune system is an amazing thing. It sees these bacteria and it kills them. It takes care of them, but sometimes it's not enough. And we have too much bacterial load, the cut's too dirty or something, and these become multiplying rapidly. So what we need is an antibiotic. We use a drug called an antibiotic, and that kills those bacteria off, and the person regains their health. So the antibiotic, along with our immune system, makes the person healthy again. So that's the ideal situation here. Unfortunately, what we're seeing after 79 years of using antibiotics is this unfortunate thing called drug resistance. Bacteria are living organisms, and they don't stay the same. They either die in the presence of these antibiotics, or they find some mechanism to survive it. And that's pretty much the same with any living creature, is it either goes extinct or it finds mechanisms to adapt. And bacteria, their ability to adapt is actually a weird one, because they find ways to adapt by going through mutations. They're so inefficient at making new cells, because they make them so quickly, that a lot of these bacteria make mutations as a result. Most of those mutations result in cell death. The cell dies from this. But occasionally, every once in a while, a mutation actually makes it able to survive its environment. In this case, the environment is this antibiotic. And so you see this here. We're talking bacteria multiplying by the billions. Okay, so there's a lot of opportunities for one or two to have this resistance to this antibiotic. So we treat, and now we've got a resistant bacteria, and all the other ones die, just like we wanted them to. But if our body can't take care of these newly resistant bacteria on its own, sometimes we do, but sometimes we don't, those begin to replicate, and we get this infection with the resistant variety. And now that same antibiotic that we would have used before no longer works. And so now we have to go to a different agent. And luckily, we do have a lot, we have a fair amount of options, but it's always going to be an arms race between the bacteria coming up with ways to survive and healthcare trying to find ways to make new antibiotics with different ways to kill these. Okay, so that's kind of where we're at, and it's going to just be something that we're always dealing with. This is my kind of cheesy diagram. This kind of orange peach blob here is representing a bacterial cell. Totally doesn't look like that in real life, but this is in this case. So just how has bacteria fought back? I mean, like, how do they do such a thing? Well, there's a couple ways, 3 ways that I put here. There's others, but these are some of the main ones. So what antibiotics can do, and I mentioned it before, is they can come in and bind to this outer structure, this peptidoglycan that surrounds the bacteria. They bind to it and they cause disruption and cause the cell to die, the bacterial cell. But this mutation that this bacteria has developed here makes that binding site kind of strange. It doesn't allow the antibiotic to bind to it, right? So therefore, if the antibiotic can't bind to it and do its thing, then the bacteria lives. And that's just a protein that has been altered by that bacteria. Another way that's happening, this one's kind of, now they start getting a little bit cooler. This is an inactivating enzyme. That sounds pretty intense, but what the bacteria does is it has developed an enzyme to basically chew up this antibiotic and make it ineffective. So as soon as the antibiotic gets into the bacteria, this chews it up and makes it inactive. One of our most famous ones, penicillinase, just like it sounds in the word, it's an enzyme that inactivates penicillin. Okay. The third kind here is, I think this is the coolest one. I mean, it's not awesome that it happens, but it's crazy that the bacteria were able to come up with something like this. They developed efflux pumps. In other words, the antibiotic gets into the cell and then pumps it right back out. They get these pumps that pump the antibiotic right back out. So it's kind of like a sump pump for the bacteria. It just comes in and pumps it right back out so it can't do its thing. And so the bacteria becomes resistant to the antibiotic. So those are a few different ways that we see this happening. All in all, exposure to antibiotics is the #1 reason that bacteria develop resistance to the antibiotics. So kind of boiling it down is the more exposure we have to them, the more resistance develops. Okay, either both in ourselves and in the population. So our goal here is to make this exposure less, at the same time able to treat people effectively. So I just put this table in here just to show you, there was kind of, when we start with any invention or discovery, I think something that's really cool, really awesome, and changes lives, I think there's a tendency to use it and overuse it and use it some more. All right. And we could think of this even in a sense of oil. When we found ways to use oil for cars and vehicles, we use it and we use it and we use it some more. But after a while, initially, we don't know the negative effects so much because we haven't had enough time to study it. We only see the good part. Well, there's usually some kind of a negative effect as well. You know, with burning gas and oil, well, we put more pollution into the air. We put more carbon dioxide in the air. So now we're starting to see the negative effects of that. The same thing is true from our 79, 80 years of antibiotic use. All right. So it's not all good. And I think there was a narrative for the longest time in our culture, in our society, and still is there, that if in doubt, just give the antibiotic, and there's no bad things that can happen, but only good things. This table makes it look like there's not very many good things and all bad things. I don't want to don't misinterpret me. This one right here, this upside to antibiotic use, is a big one. It's miraculous and it is important. Okay. And we're going to continue to need these agents. And the reason they're precious agents, because we can treat and cure infections, deadly infections caused by bacteria. And so we want to be able to have these antibiotics when we need them. So this is like, I made it in bigger font. I should have made it in even bigger font because it's the most important part of it. However, there are some downsides to antibiotic use that I want to point out, and reasons that we want to make sure that we are being good stewards, taking care of our antibiotic use. What we're finding, and I've talked about that a lot so far, is that more use equals increased resistance, makes them ineffective. They won't do anything against viruses, and oftentimes illnesses from bacteria and viruses on the outside to the patient can look very similar. And I'll get to that in a little bit, but they're not going to do anything against the common cold, influenza, COVID. All those things are not touched by antibiotics. Okay, different treatments for those. There's side effects, and this is one that we're seeing more and more. In fact, one of the most common ER visits that we see is, or I should say, one of the most common medication-related ER visits is antibiotics. I think 20% is the number that I saw on the CDC. Is 20% of all medication-related adverse effects come from antibiotics. So of all the thousands and thousands of medications out there, antibiotics are like 20% of them. Okay, so they're hard on the kidneys. We have to dose these things typically at lower doses if your kidneys function is not as good as it should be. They oftentimes cause nausea and vomiting, diarrhea, and things like that, and other specific side effects to antibiotics. For example, we would avoid treating you with a quinolone antibiotic like levofloxacin if you are an athlete, because it can cause tendon rupture, and we don't want that to happen. The last one here is persistent antibiotic use can also lead to opportunistic infections. The bad guys like C. difficile. It's just like it sounds. It's very difficult to treat C. difficile. And there's actually many bacteria that are good in our bodies that we want to keep there. But if we kill those bacteria, then we leave ourselves open to these bad ones. All right. So I just want to hang on to this last point here for a minute, because this is a really important one. And I have lost my ability to. There we go. So right here you see a yard, and hopefully our yards look like this here in about a month. All right. So people that are really good to their yards and treat them well, theirs will be looking like this sooner than later. Occasionally, we'll also see this little guy come in there, right? These pesky weeds, you know, and dandelions. And I get a lot of dandelions in my yard because I don't treat my yard, and that's the problem. But it's a really good analogy of what we have going in your gut. Think of this grass as the good bacteria in your gut, okay? And think of the dandelion, all pretty here, right? This thing will multiply and go crazy in your yard if you let it. Think about this as the bad bacteria, like the C. diff, right? What happens, or many of you out there think to yourself, okay, how do I keep these dandelions out of my yard? Well, one of the best ways you can do that is to have a healthy yard. If you have a healthy, thick grass yard, you know, you treat it well, you give it fertilizer and those types of things, and good watering, that grass is going to be healthy and not susceptible, open to these bad weeds, right? Think of that. So the analogy there is, if we treat our bodies well, if we have a good diet, it's kind of like fertilizing our good bacteria in our gut, right? There's a lot of other things that good diets will do for us, but this is one of them. Good fiber in our diet. Sarah also mentioned before we started here, probiotics, and in probiotics, you know, while there's, I'm not going to be I'm not a terribly good expert at that. There's not a ton of good data about it, but we do give probiotics for patients who are on antibiotics a lot. And the reason we do that is to kind of help promote the growth of this good bacteria in your gut. What happens if you want to get rid of these weeds? All right, let's say you get a few more weeds that you really like, and you don't really want to go out and pull all of them. Well, you can put on a herbicide, right? We're pretty good at that in Iowa, putting herbicides on there. Now you got to decide which herbicide to put on there. You go to the store and you get to see a whole bunch of different things. I would recommend the one that doesn't kill the yard too, all right? Make sure don't pick the Roundup. Because what happens if you put Roundup, and maybe you've seen this major mistake before in somebody else's yard, where the whole yard has been completely killed off, all right? And sure, you got the bacteria, or you got the bad bacteria or the weeds. Yeah, you got those, but you also got everything else too. So I like to think of this as if we take a broad spectrum antibiotic, and it's not that as dramatic as that, but in time, if we continue to give our cell to take a broad spectrum antibiotic, like a broad spectrum herbicide, Roundup would be an example, we kill everything, right? We kill everything, including the bad stuff, yes, but we also kill the good stuff. So what happens after a couple weeks of this yard that has nothing growing in it? Is it the grass that comes back right away? Not usually. You usually not have a weed problem, don't you? Unless you're really going to have to work it over now. You're really going to have to put a lot of effort into seeding and taking care to get that grass back, because the weeds, they don't have any problem coming in. And you're going to have a lot of them. Think of that as the bad bacteria. And that's what happens if too much broad spectrum antibiotic use leads to opportunistic infections. Think of those as the weeds, okay? So we want to, and I'll talk just a little bit more as we get down to the bottom here, but that's a big one. So just real quick, because I really haven't defined what we do with antibiotic stewardship. This is what we do in the hospital and in outpatient settings as well, is manage antibiotics to maximize their benefit, treat infection, minimize the harm, all those bad negative effects that I just talked about, and keep as many antibiotics as useful as possible for as long as possible. So remember, this is a race. This is a battle between bacteria and antibiotics. And if we can keep as many of these agents useful as long as possible while we start to get more useful agents on the market, we can win the battle. We can win the race. But if we overuse them, remember, the number one reason for resistance is exposure. So if we overuse them and we get more and more resistance, now we're starting to lose the battle, because bacteria are starting to overcome all of our agents that we have to use. So our goal as stewards, as antibiotic stewardships committees, and in pharmacy, is to try to get as little exposure as necessary to treat infection. Okay. So more specifically, what are we doing? Well, you might see some of these things happen if you get an antibiotic. It's a little different than maybe the past. Your doctor may start you on a broad spectrum antibiotic, and that still happens because we don't know what bug it is right away. It takes some time for a culture to grow the bacteria and figure out what it is. So we might have to hit you with a broad spectrum antibiotic. But as soon as we know what those culture results are, your doctor may switch you to a more narrow spectrum antibiotic, something that only targets the weeds and not the yard as well. All right. So how can we, and that's one way we can do this, is narrow that spectrum down quickly. We can reduce the duration of therapy. A lot of studies are coming out to show that we can treat most infections within 7 days. The past, we would have treated you for 10 to 14 days. Even if you felt good, we always would say, the last thing we'd say is take it all till gone. Okay, make sure you take all of it. So even if you're feeling better after a few days, which we hope you are, we want you to take for another week. But we're starting to see that that's not necessarily the case anymore. You can stop these antibiotics when you're recovered. All right. And still, we want to talk to your physician about that, or your pharmacist about that, in your particular case, because different infections are different. So don't just think, oh, I feel better today, I'm going to stop. Make sure you do talk to your physician about that. But these are the things that we're doing to reduce exposure to antibiotics. Another thing we're doing is evaluating allergies. Up to 10% of the population would claim that they have an allergy to penicillin. Penicillin has an unfair reputation in this regard, because the original penicillin had a lot of impurities in it, which we've corrected that a lot by and large. And so many, there's a good, fair part of our population that would say, well, I have a penicillin allergy. I don't know what the reaction was. It happened when I was young. Those folks are typically, actually, very, very small percentage of them are actually allergic to penicillin. So of the 10% of the population that says they are penicillin allergic, only about 10% of those patients actually have a penicillin allergy. So we offer this at our hospital here, and your doctor may order it. This is kind of like routine maintenance for your health care, okay? If you have a penicillin allergy listed on your on your healthcare profile, and you think you might have a penicillin allergy, we offer penicillin allergy testing, which allows us, it's just a skin test to see if you're truly allergic or not. And the vast majority of the time, you're not allergic to it. And what we can do is remove that allergy from your list, because even though penicillin was the original antibiotic, it's still really good. And there's still a gold standard for many of our infections. And medications like penicillin and its derivatives, we don't want to not take those because we are afraid of what might happen if we take them, and you might get an allergy that looks something like this. All right, but this is an unfair reputation. We've overblown that, and we end up doing is giving you more broad spectrum antibiotics because those are the only ones that we have available that are not penicillin, and then we run into all the other problems as well. So it would be good if we had this available for you when we need it. Okay, so that's one thing we're doing. What can you do? So this is my second to last slide here. What can you do to help in this fight against antibiotic resistance? So there's a couple things. The first one is a healthy lifestyle. And this is probably a common thread that goes through most of these Educating, Empowering You sessions. And this is another one. It's maybe not as obvious, but a healthy lifestyle will keep your immune system strong. And remember, way back at the beginning, I said our body's immune systems are amazing. They will take care of infection before it gets out of control many times. That's why patients that have a compromised immune system, have low immunity, a lot of our patients, especially who are on chemotherapy agents and stuff, they're very susceptible to infection. But most people walking around out here, we get a lot of bacterial exposure all the time, but our immune system takes care of it. So we can help ourselves by having balanced diet, plenty of rest, plenty of fluids every day, and make that a habit, right? It does so many other things besides keeping us from having to have illness of needing an antibiotic. It cures many other things too, but this is one of them. If we can keep ourselves from having antibiotics in the first place, then we are ahead of the game. We're kind of putting money into the bank when we really need it later, okay? The second thing is, don't expect your doctor to prescribe an antibiotic. We're trying to work really hard on educating the public, and I did this by going to the high school. And if there's anybody out there who wants me to come speak to an organization or something, I'm willing to do that, because we're really trying to change the narrative about antibiotics. They're not always appropriate, okay? If you go in with a stuffy nose and a cough or something like that, in the past, your doctor may have just given you an antibiotic. They may feel pressure from the patient to get one because you're expecting something and you want to get better, and you want to get better right now. But it may not be appropriate. Many times those are just viral infections that will not be cured by an antibiotic. In fact, if it's a viral infection and you take an antibiotic, now you bring in all those bad negative effects into play as well, right? And the third thing is keep your vaccinations updated. Vaccinations will help keep your immune system strong, help keep you, for example, a lot of these vaccinations are for viral illnesses like influenza. But a lot of times what happens is a patient might get influenza and now their immune system is compromised. All right, they are really trying to fight off this viral infection, and now they're exposed, and now they can get other things too, like bacterial infections secondary to that, and then you need antibiotics. So we could have prevented that if we would have, had our vaccinations updated, and that's kind of the package there. This last thing is just one thing that came from the CDC's website, and there's a whole bunch of stuff on there that you can go look at. Really easy to read, but this is one that I like, and it just shows some of the common things that you might go to the doctor for, and whether it's a bacteria, a virus, or could be either one. All right, so maybe the doctor will have to do some tests to find out. For example, a middle ear infection could be a virus or a bacteria, and in the past we would just give an antibiotic right away for an ear infection, but now we promote watchful waiting. Okay, you can wait it out a little bit, and a lot of times that ear infection will go away on its own. Our body will take care of it on its own without taking an antibiotic. You can just use some pain relievers and stuff like that if there's some pain there. So there's some of these things. Remember, runny noses, common cold, sore throats, except for strep. They'll do a strep test, flu. None of those are going to be effective with antibiotics. So that is that's my presentation. And if there's any questions out there, I'd be willing to answer those.
Michael, you did such an awesome job covering so much information. I can see why you are a teacher. I don't know if you were a born teacher or that was something that you grew into, realize that you're a good teacher, but you did an awesome job. So if anybody out there does have a question they want to throw in the chat, please feel free to do so. I had a couple of thoughts that I wanted to follow up with, but first of all, just complimenting you on weaving in the history and teaching us, giving us that science lesson, and just really giving us a thorough explanation of all of that. I found it to be very fascinating. I think one of the questions that I came up with, and I think you're alluding to this, but I'm curious, so the less antibiotics that we have, then the more our body lowers that resistance, correct? I mean, like, are we continuing to, so it's when we're producing the resistant cells, because antibiotics are present, if they're not there, then we're losing those resistant cells and starting to produce the healthy cells again.
Yeah, well, that's a good question. And the resistance is in the bacteria itself. So imagine having a bacteria in your body, right? Which we do. We have bacteria in there. Maybe it's one that shouldn't be there. That bacteria has there's no push like to make it evolve or anything if it's not exposed to some insult that keeps it from replicating. The second we expose it to something that'll kill it, like an antibiotic, that's when and I'm not just talking about, I shouldn't say one bacteria, there's a bunch of them usually, right? It's not just one, there's a grouping of them. That's when the pressure, this adaptation pressure starts to be placed on that population of bacteria to then mutate in a mutation that could then become resistant. So yeah, I don't know if I answered your question, but it's mostly there's a lot to it scientifically, but in the take-home message is that the less we provide this reason for the bacteria, aka antibiotics, to mutate, the less they will. They'll just sort of stay status quo, right? So there's that. Kind of like if you were to take I won't get it. No, that's not a great.
Go too far into the weeds.
Yeah, I'll go too far.
It sounds like adaptation is kind of the key word there. Like the cells are adapting to kind of whatever is going on in the body. So that's what goes back to kind of your original statement too about a healthy lifestyle and feeding ourselves like from a positive perspective to begin with, and then that way we're kind of keeping those cells healthy versus the bacteria coming in and then having to treat it. And then obviously like you were saying too, there's a place for it. It is a life-saving miracle drug that we absolutely need, but to your point also earlier, more and more we're wanting to use it less and less in order for our body to be able to fight those infections on their own, so to speak. So do you have a recommendation, like based on this information, and the screen being up right now is kind of perfect in terms of, if somebody is running a fever, we've always been taught that your body is then doing what it's supposed to kind of help fight that infection, for example. At what point do you feel like there's a tipping point, of when we should go to the doctor versus not?
Yeah, and I think that's a good question. I'm not discouraging anybody from going to the doctor. I think you're because there's always that point like, hey, do I you know, maybe I've got a deductible. Oh, maybe should I go? Should I not? Are we just gonna be okay? I think you know, all of us have that wonderment, and especially when it's with our children. Um, don't feel bad about going to the doctor for any of this stuff, right? In fact, I would encourage it. It's just, I would say that don't expect to walk out of there with necessarily anything to treat it. The doctor may look at some labs and may consider, you know, what kind of fever you have, what's already in the population, what they've been seeing lately in the doctor's office, and they might conclude that this is a viral infection. And the recommendation for you is plenty of fluids, rest, stay home, those types of things, and don't feel like walking out of there like you should never have come in the first place, because you now know. Because you can see there's a few things here, you know, and even these have symptoms that mimic some of this stuff, right? And so we don't know, as just a common layperson, I don't know without going in there and finding out and having them maybe do some tests and swabs and those types of things. So it is very difficult for the population to know. So I would still recommend, you know, go to the doctor if you feel like it's something that's not getting better, or right away if it's, you know, if you have a super high fever. You know, usually bacterial infections are have a fairly high fever, you know, 102 plus kind of thing. If it's a low grade fever, 101 or less, a lot of times I'm just throwing some arbitrary numbers out there. That low grade fever kind of indicates viral infection a lot of times, but not always. So, yeah, go to the doctor and see, and let them make that decision, help you make that decision on that. And they'll tell you whether you need an antibiotic or not. So.
And I think you also said this too, or again alluded to it, that it's kind of like the petri dish, you know, where they can, if you do go to the doctor, they can take a swab and put that in a petri dish, check it out, see what, you know, comes of it. So in a couple of days, they might find that it is bacterial and that you do require an
Right.
antibiotic. Is that fair to say?
Yeah, that absolutely. They might send you home. My culture may think it's looking like viral, but they find that, well, no, it was bacterial, and then they maybe call you up and send a script in for you to go get it picked up, that type of thing. That could happen too. So.
Yeah. Well, super helpful. I'm not seeing any questions in the chat, but you did also mention that you would be willing to go out and speak to, you know, high school students or other groups that this may pertain to in terms of educating people. So I'm just wondering if you can, maybe for the sake of the recording, just state the best way to get a hold of you, maybe a phone number here at the hospital or an email address.
Yeah, you know, you can get a hold of me if you call. My name's Mikel Brandhorst. Once again, I go back to the top here. I don't have my contact information here, but if you call the main hospital line, they can, and just ask for the pharmacy, they'll direct you up here. I'm going to butcher the number. Is it 515-432-3140? Is that the main number?
Yep.
I did. Okay.
Yeah.
Or you can email me at Mikel Brandhorst, just all one, at bchmail.org. That's Mikel Brandhorst at bchmail.org. And I love doing that stuff, going out and sharing this, because I'm particularly passionate about this, and it's a really hot issue right now. And I miss the classroom in ways. So it doesn't have to be a classroom of high school students. It could be a classroom of any age grouping, and of any size. So I'd be willing to do that. So yeah.
Excellent. Well, that is wonderful. And again, you did an awesome job of really laying this out for us and just giving us some really helpful information. So thank you so much, Mikel. And with that, again, I'm not seeing any questions, so I think we can sign off for today. And thank you so much again for your time and presenting today.
Thank you. Have a great day.
Thanks. You too.